Before we get started, we want to thank our sponsors. Primarily, the Arizona Healthcare Cost Containment System is our primary sponsor for this event and the whole Recovery Home Academy webinar series. And of course, Project ECHO is a co-sponsor and responsible for helping us make sure that you can get continuing education credits for the series. And then of course, the Arizona Recovery Housing Association, which has been helping us for the past few years think through some of these things and give us a lot of important information for how we can best build out technical assistance for recovery homes. So again, I'll say it one more time. If you have not yet, please be so kind as to put your information, affiliation, email, and organization into the chat so that we can make sure that you get those continuing education credits. You will also get a post-session survey, and that's maybe even more important than letting us know that you are here. So at the end of our session today, you'll get a link to a post-session survey for an evaluation so that you can tell us how you felt about today's learnings. And that will give us the information we need to send you that continuing education certificate. So again, please let us know if you don't want to be included on our email lists. I just want to hype our Project ECHO series of which this is a part. This is just a small, brief series, but Project ECHO has lots of ongoing series, and of relevance to the folks in the room would be the behavioral health integration, the veteran community care, of course, our medication for opioid use disorder ECHO, and then the substance use disorder treatment for women ECHO. And those happen every other week, so please join us. You'll get the slides, by the way. So if you're like, oh, I didn't catch the Project ECHO link, you'll get the slides after our session today. So you can grab up all those links and you can register for those ECHOs if you'd like. If you'll bear with me for a moment, I have to read to you. In support of improving patient care, ASU is jointly accredited by the Accreditation Council for Continuing Medical Education and the Accreditation Council for Pharmacy Education and the American Nurses Credentialing Center to provide continuing education for the healthcare team. Continuing education credits for psychologists are provided through the APA, Office of Continuing Education. The APA CEP office maintains responsibility for content of programs. As a jointly accredited organization, ASU is approved to offer social work continuing education credits by the Association of Social Work Boards approved continuing education program. Organizations, not individual courses, are approved under this program. State and provincial regulatory boards have a final authority to determine whether an individual course may be accepted. ASU maintains responsibility for this course. Social workers completing this course receive 1 credit, as do psychologists, as do some other folks allied with behavioral health. And also we have an interprofessional accreditation. So what that means is even if you're not in any of those disciplines, you can get a certification suggesting that you did this training and you were here, and you'll still get a nice certificate that you can maybe give to your employer. Just a note, based on some feedback we got from our last webinar, which was the fundamentals of recovery homes, some folks maybe thought that ASU was profiting from these webinars, and I want to just make it absolutely crystal clear. We are not profiting in any way whatsoever from any of the technical assistance or webinars that we create at ASU. ASU's role is only technical assistance. We are not providing any sort of oversight over any programs. We're only just here to offer some ideas and guidance, largely based in the empirical literature. So very simply, we are not getting much out of it except for the reward of being able to help guide good practice. To that end, here's some other webinars. These are 3 webinars coming up under our Recovery Home Academy. We have peer competencies coming up, development and sustainability strategies, where we'll talk about building out your recovery home program. And then of course, ethics and community considerations, all under the recovery home umbrella. So again, we'll send the slides so you can capture all those links and you can come to all those webinars through December. Okay, so I did a lot of introduction just then, but I have a couple more introductions I want to do because I am not an expert in medication for opioid use disorder. So I can say that I'm maybe a behavioral health expert, sort of largely related to the research in behavioral health, but I'm not a direct practitioner anymore. I used to be many years ago, but primarily what I do these days is research and workforce development. So to that end, I feel like I have some competency to talk about very basics of MOUD 101, but I am not the expert in the room. I've invited experts to be here with us, and those experts are Dr. Michael Decker, who is on camera, hi, who's an addiction psychiatrist. And then we have Carissa Riggs, who's a family nurse practitioner and works for Success Care and West Valley Health Equity. So these two experts are here because they are experts in medication for opioid use disorder. And so they're here to answer questions to that end. As I said, I'm not in direct practice anymore. So I also invited and we have with us clinical professor Liz Athens from the School of Social Work, who is a lot closer to direct practice than I am and have been for a while. So I'm hopeful that these three experts can help field some questions. And then if there's things that come up during the course of what I'm tossing out at you and you want to put questions in the chat, then maybe I would ask the three of those experts to keep an eye. Feel free to hop in and answer a question if you see something come up that you have some expertise in. That would be great. Anything else from my experts that you would like to add before we go on to the next stuff? Cool. Thank you so much. Again, I really, really appreciate you being here just so that we can make sure that all of the correct information is delivered to our provider community. I think that's really, really important. And at ASU, we really pride ourselves on making sure that whatever we deliver is quality content. And so that's how we're ensuring that that happens today. We'll talk about learning objectives. We'll talk about some really basic definitions of OUD and MOUD, myths and misconceptions, and then maybe most importantly, we'll talk about the client-centered approaches to this practice. First and foremost, we hope that you exit this whole session having a better understanding of opioids, opioid use disorder, and co-occurring disorders, probably more so related to opioid use disorder, specifically and MOUD in particular. We hope you recognize and address some myths and misconceptions, and you know where to go for guidance. One place that you can go for guidance where we have access to a lot of experts is the MOUD Echo, by the way. And we hope that you are encouraged to reflect and discuss with your team how MOUD can promote recovery journey across behavioral health settings. So let's start like really basic 101 level, because that's what we're here to do. What are opioid use disorders? Well, opioids are, of course, a class of drugs that work by binding to opioid receptors. Opioid receptors are involved in a lot of functions, including how we perceive pain, our moods, and the way that we perceive rewards. And so when opioids bind to those receptors in the brain, they can produce a lot of different effects, including pain relief and euphoria, a sense of being high potentially, and also relaxation. Opioids work by blocking those pain signals that could otherwise reach the brain. Sorry. They also increase the release of dopamine, which is a neurotransmitter that plays a role in reward and pleasure. And that's why opioids can become an addictive substance. Opioids are used to treat lots of different pain conditions, including severe pain, acute pain, chronic pain, pain associated with cancer, for example. They're also used in non-medical purposes, such as getting high or to relieve stress or anxiety. People are using opioids for those reasons as well. But here's a basic analogy to describe how opioids work. So imagine that your body has a pain alarm system. And when you get injured, that alarm system sends signals to your brain to let you know that you're hurt. Well, opioids work by turning down the volume on the pain alarm system. And so they also make you feel good, which can help distract you from the pain. They can also be dangerous. Of course, we know that. They can cause serious side effects, such as constipation, drowsiness, nausea, vomiting. We're going to talk about those a little bit more in a second. They can also be addictive, as I've mentioned, and overdoses on opioids can be clearly a fatal problem. It's important to use them as they're prescribed by a doctor, and that's really a fundamental point we want to make here. So if you have any concerns about opioid use at all, one of the fundamental things you should do is talk to a doctor or medical provider, healthcare provider about those concerns. So examples of opioids would be morphine, oxycodone, hydrocodone, and then of course, Some illicit opioids we might consider being heroin or potentially fentanyl when it's not prescribed by a physician. So this is probably more information than we need to discuss MOUD, but I think it's important foundational information. So this is how we diagnose opioid use disorder. So the important thing to remember or to know about this is that there's degrees here. So some of our opioid use disorder criteria are listed, well, all of the criteria are listed here if your practitioner is using something called the Diagnostic and Statistical Manual of Mental Disorders from 2022, which is the most recent version. So these criteria let folks know, or let your providers know rather, that you could potentially have an issue related to opioid use disorder. They might not absolutely designate you as having an opioid use disorder unless there's a set of assessments that are completed and they have talked to you and they feel confident in making that assessment. So these are just a guideline. So to that end, let me go through them really quickly. Opioids taken in a larger amount or over a longer period of time than intended might be one criteria. Persistent desire, a lot of time spent in activities necessary to obtain. Craving, recurrent use resulting in failure to fulfill major obligations, continued use despite having persistent or recurrent social problems, important social, occupational, or recreational activities are given up, recurrent use in situations where it's hazardous, opioid use despite knowledge of having persistent or recurrent physical, psychological problems, tolerance as defined by a need for a markedly increased amount to achieve intoxication or desired effect or a markedly diminished effect with continued use. And then lastly, withdrawal as manifested by withdrawal symptoms. So if you have two of these things, then you might be considered to have a mild opioid use disorder. These are rough estimates. Moderate, potentially 4 to 5 of these criteria, and then it could be potentially severe if you have 6 or more of these criteria. And so this is to sort of contextualize what we're going to talk about. But importantly, I want to say that this is a label, and mental health diagnosis can be, of course, very stigmatizing, and that people with diagnosis such as this can face a lot of discrimination related to employment, importantly, discrimination related to housing. And we should mention that, especially because this is under the umbrella of the Recovery Housing Academy. Discrimination reflecting areas in education, other areas of life. Mental health diagnosis can really reduce people to their symptoms, which is something we absolutely want to avoid as clinicians and practitioners and people working as peer support specialists. We need to understand that this is a criteria that's largely used to make sure that providers are reimbursed for services, and not a criteria that should be used to identify or define anybody's existence. I think that that's an important thing I want to point out. It is a social construction that we should be aware of as practitioners, but not something that we should define anyone by. Okay, so now that we have that context, let's roll right along. So how do you treat opioid use disorder? Well, I think the best ways to think about treating it is multi-method and tailored for what the individual potentially needs. So what does that mean? Well, it means that there's probably going to be some combination of behavioral therapies and pharmacotherapies. So I am much more comfortable talking about the behavioral therapies part of this equation. So it could be some combination of counseling, which would be an individual one-on-one kind of counseling, group therapies, such it could be group therapies that are really structured and manualized, or it could be mutual self-help could be a component of it. So it could be like a 12-step component, for example. They can be under the umbrella of a specific method or mode, like cognitive behavioral therapy or motivational enhancement techniques. It would usually involve case management. It would usually involve these days probably some peer support services. And if it's a good program and it's a holistic program, hopefully it includes things that are related to education, employment, vocation, and other assessments and services that are related to other issues, maybe like parenting, for example, or helping people exit from the justice system into back into the community. So hopefully behavioral therapies and support systems exist in good treatment programs that are holistic, but really are about helping people get to a place in their life that is more around recovering from whatever is considered their own use. If we really wanted to work for opioid use disorder, though, we're going to have a pharmacotherapy. We're going to have a medication component. So what I can say about that is that medication for opioid use disorder is the absolute gold standard of practice. It really should be considered as part of a holistic approach to treatment for folks who have an opioid use disorder. There's research to suggest that folks will get better if they're only treated with medication alone, even if there's not a behavioral therapy component. So it's really important to consider medication as a component. But as I've said, ideally we want a holistic approach that's tailored to the unique needs of the individual, and hopefully medication is considered as part of that equation. So here I want to talk about 3 FDA-approved medication treatments for opioid use disorder. Excuse me. And it's important to know that recovery home clients are really going to be working with their doctor to determine which course is the best course for their own specific goals in recovery, because it's going to be different from person to person. Okay, so this is a really cool guide. This is a little snippet from our consumer guide at the Southwest Interdisciplinary Research Center. And we will send you these guides in hard copy if you feel like they might be of value to the folks who are at your homes or your organizations. All you have to do is shoot us an email and we will get as many as you want. We have hundreds and they're about this big, and they have much more than this information. They have information related to how somebody might understand that they could have an issue with opioid use disorders that they might want to address through both behavioral therapies and pharmacotherapies. Anyway, let's talk a little bit about this piece here. So methadone and buprenorphine are called opioid agonists. And so they work by binding to those opioid receptors in the brain, and they prevent the attachment of other opioids, such as prescription pain relievers, for example. And so this can help reduce cravings and withdrawal symptoms. Naltrexone is called an opioid antagonist. And naltrexone works by blocking the effects of opioids on the brain. And so if a person is taking naltrexone, uses opioids, they won't experience the pleasurable effects of the opioid. So it can help people prevent from using opioids and then prevent from relapsing. Methadone is taken orally. It's taken once a day, and it has to be dispensed by a licensed opioid treatment provider. Buprenorphine is available in lots of different forms, so tablets, sublingual, so underneath your tongue, and films. You can get it in injections. It should be prescribed by a licensed physician, including psychiatrists, family physicians, and internists. Naltrexone is available in tablet and injection form, and it can be prescribed by a licensed physician. Other issues to consider are some things I want to point out. Methadone is FDA approved for pregnant women, or pregnant people rather, and so that's an important thing to consider. For buprenorphine, it's important to know that in the research that specific medication has been shown to be really effective when there's been social supports that are sort of up with it, but I would imagine that is true across the board with all medications for opioid use disorder. With naltrexone, there's potentially different ways to use that medication that are more maybe convenient. So that's something important to consider. But if you're considering taking methadone or buprenorphine or naltrexone for the treatment of opioid use disorder, it's important to talk to your doctor, as I've said, and really talk through the risks and benefits of each medication. And your doctor or practitioner can really help you choose which is the best for your treatment goals and whatever one is the right one for you to use. Note that some of these, methadone, for example, is covered by access, and some other medications, not so much coverage. let's talk about side effects. This is really important. And the reason it's really important is because we've been doing this recovery home technical assistance work for a few years now. And something that we've heard from our recovery home colleagues is that when folks are using medications for their opioid use disorder, that the side effects can sometimes make people appear as if they are using opioids that are not toward the betterment of or of themselves or finding recovery. And that's kind of problematic, I think, for settings when everybody really wants to move toward recovery, and there's maybe folks who have side effects that appear as if they are not moving toward recovery. So I want to just acknowledge that that's a thing. And then I want to suggest that it's really important to know that some of the side effects can be a function of improper dosing, or a need to really talk to one's provider about making sure that that balance is achieved. It could be interactions with other drugs that are happening that create some of those side effects that could be problematic on the outset, on the outside visually. To that end, then we want to make sure that there's an understanding within recovery home settings, especially between the difference between like what somebody's experiencing as a side effect that can be managed with a healthcare provider versus somebody having an issue related to problematic use, if that makes sense. Anyway, side effects that we need to be concerned with are nausea, dizziness, fatigue, restlessness, and potentially some other more complicated side effects. But in any case, something that should be monitored and discussed, especially in recovery home settings. If clients are experiencing extreme fatigue, it's not intended like that. It might happen, it might be a side effect, but it's not an intended side effect. And so it could mean that a conversation with provider is really important so that that dosage can be adjusted, or so that they can really think through some of the potential other medication interactions that are happening, because that's not how it's supposed to be. And as always, I think as peer support specialists and managers and practitioners, we want to remember that kindness and support is really indicated as clients adjust to any major change, but with medications in particular, as they navigate their recovery goals. So this is pretty important here. Let me let some people in the room. We have some folks coming in still. So important to note that the longer you use a drug regularly, the more your body becomes tolerant to it. So this means that you need to take more of it, more of the drug, in order to feel the same effect that you used to feel. But if you stop or you reduce or you change your use, your body's tolerance can decrease. And so because of this, there's a higher risk of overdose if you suddenly stop taking medication for opioid use disorder and then go back to taking the same amount of drugs that you used before you started pharmacotherapy. So the risk for overdose could potentially increase exponentially, and it's a big risk. And so important to have conversations with your physicians, with your practitioners about what could happen given various potential scenarios related to the MOUD that you're particularly prescribed. Yeah, that's what I want to say about that. Let's move on here. Before I get off the sort of the area where we're talking specifically about the definitions and then the risk of tolerance or the risk of overdose, I want to look to my practitioner colleagues in the room and see if they want to add anything there.
Go back 2 slides to the one that says side effects. One more. Okay, you see the box there on the upper right where it says there's a common misunderstanding that MOUD should only be for short-term use? That's a misunderstanding. So what happens is when you treat people with methadone or buprenorphine or even naltrexone, the goal isn't to get them like off of that treatment. The goal is to provide that treatment as long as it's still helpful to the patient. So long-term use of these medications often happens. Like I knew methadone patients who've been on it for, 10, 15, 20, 30 years. Buprenorphine patients generally not as long, but the medication's only been around for about, 15 years. So go one more slide, because there was another point in the upper right. To show kindness and support and not be, so you don't want to come at these patients with you shouldn't use drugs type of attitude. It should be more along the lines of open, I'm interested in what's going on in your life. I'd like to know more about you. Whether or not you use drugs doesn't make you a good or bad person. It's a fact of life. So let's talk everything out and meet where, I'm interested in what's going on with you. So it's not a punitive type of thing. It's more like, I understand it might be a challenge, so tell me about it. Maybe I can help.
Thank you so much, Dr. Decker. Other comments from my expert colleagues in the room?
So the only thing I would like to add, sorry, my internet's kind of spotty, is the talking about overdose. So one of the things I think it's really important that we don't always necessarily hit on is that you can still overdose while you're taking any 3 of these medications. So any 3 of these medications is not like your fail safe, that you're safe and protected from overdose. You can absolutely still overdose while you're on any of these medications. And I think one of the scary things is if you are mixing any of these medications with external opiates like fentanyl or heroin, you may not even realize that you are overdosing because you wouldn't necessarily feel the effects because of the medications that you were taking. So I think it's really important to make sure people know that. Also mixing like benzos and alcohol and their kind of depressants.
Broke up just a little bit there at the end, but I 100% don't mix alcohol benzos with these medications.
Thank you, colleagues. Okay. Let's talk about some myths related to opioid use disorder. So one myth is that MOUD could get in the way of recovery or potentially slow it down. So some of you maybe might have heard that at some point, but I would suggest that MOUD is a proven treatment for opioid use disorder. It really helps people manage their cravings and withdrawal symptoms. It helps them to stay away from problematic opioid use and does not slow down recovery. In fact, it can help people recover more quickly and more effectively, assuming everything's aligned, assuming that they have a good relationship with their provider and they're having ongoing communication with their providers to make sure that everything is copacetic. Another myth is that people could use MOUD just to get high. Well, it's not a recreational drug. Medications for opioid use are not for that purpose. They are medications to treat opioid use disorder. They don't produce the same euphoric effects as opioids, and they can actually make opioids less pleasurable to use. So just really important to remember that medication for opioids are safe, effective treatment. They've been used for decades to help people recover from opioid use disorders, and it's not a substitute for problematic use. It's a comprehensive treatment that in combination with other behavioral therapies can be really effective and has been shown to be empirically very effective. And it can help people live normal and productive lives. It allows them to go to work, to go to school, to spend time with their loved ones, to manage good, healthy relationships without being preoccupied with thoughts of addictive types of patterns and use. And it's important to remember really that everybody's just different. And so what works for one person might not work for another person. There's really no one size fits all approach to treating substance use disorder, even sort of more broadly. And medication for opioid use disorder is a really important tool that can be used to help many people recover from opioid use disorder. Any additional thoughts from my practitioner colleagues about these myths and misconceptions? Okay, cool. I have another one. I have another set. Someone isn't really sober if they're using medication for opioid use disorder. Well, When properly dosed and monitored, MOUD should not impair people's cognitive or physical abilities. It should not interfere with their ability to live normal, productive lives. Another one I bet we've all heard is that MOUD is just swapping one addiction for another. And I will say this. People who take medications for opioid use disorder are not addicted to medication. They are in recovery from MOUD. MOUD is a tool to help people achieve recovery and to help them be normal and productive in their lives. It should not be considered a sign of weakness or failure. It should actually be a sign of strength and courage and sort of motivation to achieve recovery and to achieve wellness. And again, important to remember that everybody's different and everybody's on a different recovery journey. Anything to add there?
So I love addressing these in clinical settings, in group settings, because I think a lot of people have some really kind of underground bias around what recovery is supposed to look like. We see that in peer-driven community support programs, but I think that we also see it internalized with people as well. So they'll say things like, if I was really strong, I could do this on my own. And, and that is, from a clinical standpoint, that is a wonderful thing to start initiating discussion around why people think that way. So I always have addressed these things, especially in group settings.
Thanks so much, Liz. So to everyone in the room, people who are in direct practice, really thinking through and reflecting on how those kinds of ideas could harm people as they're experiencing treatment is a really important thought exercise. You want to add to that, Dr. Decker?
I do. So I was actually asked this question when I testified to the Arizona Congress, which is, isn't the MOUD treatments just swapping one drug for another? And I explained to them, treatment versus illicit substances are very different. Treatment restores the function of people, whereas illicit substances generally remove the functions of people. So that's where you want to see a big difference, because someone in treatment is they're making an appointment, they can come in and do things, which means they can go to work, they can function in their regular life, whereas the addiction will remove those functions. So that's the big difference between drugs versus treatment.
Thank you for that. Krista?
Can I just add one more thing? Sorry. So I feel like one of the myths around the whole swapping one for another, or, I've got using a crutch. So the stigma that's outside of treatment is also inside of treatment, kind of to touch off of what Elizabeth was saying, right? So I always bring it around to, you are a human being and you don't deserve to suffer. Like, I don't care what you think you've done in the past. I don't care what you've been through, what you think you put others through, whatever that is. Doesn't mean anything, and you are a human being and you deserve to be treated, and you do not deserve to go through any kind of pain or discomfort for any freaking reason. So I always like to just kind of touch on that.
Thank you so much. We've had very strong advocates in the room. I appreciate your voices. So some key takeaways, just to underline everything that we've been talking about here. Time on MOUD really is going to vary depending on the patient or the client and their personal needs. Definitely a conversation between a provider and a patient or a client. MOUD has been shown to improve quality of life empirically. We know this from the research, and overall functioning while someone is on their recovery journey. So instead of focusing on those cravings, they can focus on recovery and healing. MOUD is another tool in the toolbox, just as medication is used to treat and manage other conditions like diabetes, for example. MOUD can be a component to the successful treatment of addiction. MOUD acts as a bridge between the biological and behavioral sides of addiction. So individuals can engage in therapy or other services to help them on their recovery journey. And so a holistic approach would include a lot of different tools that would meet and be tailored to an individual's needs. Let's talk about client considerations. These are going to be really related to things we want to think about in a recovery home setting. So some things we want to absolutely underline. Thank you, National Institute on Drug Abuse, with its 13 treatment principles. But we want to make sure that we understand that addiction is a complex but treatable disease, and it is a brain disease. It's affecting brain function and behavior. No single treatment is appropriate for everyone. There is no one-size-fits-all method of treating folks. Needs to be readily available. Ideally, treatment is accessible and readily available to those who are needing it. Effective treatment attends to multiple needs of the individual, not just their use. So as I mentioned before, effective treatment is holistic treatment. It's not just treatment that's attending to behavior or even physical or physiological dependence. It's treatment that also considers the fact that people need like a place to live and they need to maybe help navigate their social relationships. And lastly, an individual's treatment and services must be assessed continually. So that's to suggest that this is a process that ebbs and flows. Recovery is not just, I decide I'm going to be recovered, and so now I'm just going to move in that direction. It has the process that looks more like a spiral, and sometimes people move up toward recovery, and sometimes they come back down a little bit, and sometimes they sort of vary along the path toward recovery, and that's sort of how it looks more often than not. To that end, our treatment from the practitioner side, or even our treatment from our social and community embedded providers, like those who are running recovery homes, should consider that individual needs are going to change, as their recovery journey is not going to be a linear path in one direction. So related to recovery housing, housing is not just a physical shelter. It is a social determinant of health. It is essential for individuals' physical, emotional, and socioeconomic well-being. It affects communities, governments, nations through its impact on the economy, healthcare system, workforce, and more. So housing is absolutely a critically important part of this whole conversation. And what we need to know is that it is illegal to discriminate against individuals for their use of medications for opioid use disorder. Recovery homes cannot deny services simply because somebody uses medications for opioid use disorder. As a matter of fact, it is in our legislative policy that folks who are running recovery homes, in order to be licensed, have to accept people who are on medication for opioid use disorder. Here's the thing, though. While the law states that folks must accept folks who are on medication for opioid use disorder, there's not a specific type or condition, which allows quite a bit of flexibility. I don't know if flexibility even seems like too positive of a term. What it does is it allows recovery homes to be overly restrictive, actually, which is problematic, right? Like we want folks who are running responsible, open, and inclusive recovery homes to be open and inclusive and accessible to folks who are treating their use disorder in collaboration with their providers. We want them to be able to access housing. But if those interpretations of accepting MOUD are too restrictive, then that really limits people's accessibility to housing services. And so we have to really think about how we can be inclusive recovery home providers, and how that means really considering how we define our own ideas of access to our services. But in all of that to say, there's not a formal policy that specifies the kinds of medications or the conditions under which people are taking medications. So it's important to know that you cannot discriminate against folks who are on MOUD, that we want to be open, accessible as much as possible to folks who are in need of housing services. Okay. We have some citation to policy here, so you can take a look at those specific legal protections at your leisure. Recovery home policies that prohibit storing MOUD can create additional barriers for clients. So it's really important to create policies that really understand where the client is in terms of their treatment. So making sure that there are, if you're having some programmatic component to your recovery home that helps people make sure they have a continuing and ongoing connection with their providers, that's in consideration of the fact that you want them to take their medications appropriately and consistently and aligned with what their provider expects. And so ensuring that you make reasonable accommodations for that to happen, right? So what does that look like? Well, it looks like making sure they have access to their medication. If they're allowed to have their medication with them, they should be able to have access to it in a way that keeps it safe and protected in a locked box, and so that other people don't have access to it. And so that there's some privacy in how it gets stored. And then, of course, if they are not able to have their medication with them, then maybe there's a place to have a conversation about how they can make sure to get to their provider consistently so that they can have access to their medication regularly as part of the program of their living setting.
Hey, Tasha, can I make an observation?
Please.
So especially in recovery housing, if someone chooses to leave against, before their completion of their program, one of the things that I always am cautious of is that if people have their stuff in a lockbox and they don't have access to it and then they leave, then they don't have their medication. So in the days of sort of more concerning behavior that I saw around that is that people would not be allowed to have any of their belongings if they chose to leave against clinical advice. And so then we would have people out unhoused without their medication on a Friday night, no access to their doctor. So I've been happy to see that licensure for recovery homes and Oxford houses require that people have access to all of their medication. So not just an MOUD. But I had a fair amount of clients who were either kicked out of their sober living or at the time we were calling it sober living, without access to their medication. And that caused, obviously all kinds of problems.
An important note that I want to highlight too is when we're talking about sober living here in this specific setting, in this webinar, and as part of our Recovery Home Academy, we're really talking about what is known as level 2 recovery homes. So level 2 recovery homes and even Oxford houses are settings where people are living independently, like they're not having a lot of clinical oversight. So that would be different, right? So when Liz is talking about having access to their medication, being able to take it with them, we're really talking about that level of service on the continuum. So not really talking, it's a different story if we're talking about like a residential treatment setting. We're not talking about residential treatment settings. We're talking about the kinds of recovery homes where people are pretty much operating independently and there's nominal amount of programming, likely mostly peer support services. Thank you. Thank you for all that assist. So this is really important, this slide. This is maybe the most important out of all the slides, because as you probably know, there have been some issues with the operation of recovery homes over the past several months. And some of those recovery homes, many hundreds, have been operating without proper oversight or licensure. And that is problematic because that means that there are homeowners who are potentially taking advantage of people who were taking advantage of people and fraudulently billing on their behalf, which is terrible, horrible, and not affording them the services that the individual who's living there ultimately thought that they were getting when they went to this recovery home, right? So grievance process. So if you know of, or if you are maybe a client of, or if you know folks who are accessing services from a kind of setting, and I keep using my air quotes because I don't know what else to call them. They're just like homes that have a sign out that says a recovery home, but we know that's not what they are. If you know folks are being taken advantage of, if you know people are operating inappropriately or unlawfully, then you have the option to contact the state, AZDHS. You can contact ASRA if it's a home that has an affiliation with the Arizona Recovery Housing Association and there's an issue with that home, you can contact ASRA. There's a grievance process, or you can contact the Southwest Fair Housing Council. And so we have those links there, and we hope that they get spread widely, because they're really important so that people have the ability to state when things are happening that are problematic. Okay. So some more key takeaways here. MOUD is protected under federal and state laws. Substance use disorder treatment is and should be a client-centered process that's going to vary from person to person. Safe and stable housing is a really critically important part of the ecology of that whole system. And recovery homes could benefit from some training and technical assistance related to these things. So thank you so much for being here. We really hope that you had some takeaways from our conversation today. So I'm going to shut the slides down and I'm going to open up. We have a few minutes. And right now, I'm also going to shut down the recording so that